So what is the Pulmonary Fibrosis Foundation Registry? So I want to give you some history, how this started, the types of data that are there. Is anyone here in the registry? So I'll be able to show you not granular data, but what things are happening with the time and the effort and your trust to be involved in this project. These are my disclosures, which working with various pharmaceutical companies, usually around the design and concepts of clinical trials to try to study drugs to find new treatments for fibrotic lung diseases. So I've been lucky enough to be the chair of the registry since we really started talking about it 5 or 6 years ago. But it's behind the scenes. So Misha Cadet's our project manager. She does all the heavy lifting, and then I get to come up here and give you a talk and take credit for everything. So it's important, or we can spend a few minutes talking about what is a registry. If you think of clinical trials, a pharmaceutical or government-sponsored study to look at a compound, a drug, to see if it works to treat a disease, you have very strict inclusion and exclusion criteria. Who's allowed to be in that study? And then over time, the drug or a placebo are given to subjects, and you look at the end of that trial to see who did better, or were they the same? And the hope is always that the medicine works and people do better and we have a new treatment. But then at the end of the day, you look back and say, well, that was really strict. There were very strict inclusion and exclusion criteria. And maybe I'm a patient that doesn't necessarily fit that. Would this work for me? And we think about that on the caregiver side, the provider side, like how generalizable is the term we use. Registries are a different type of data. Unlike a clinical trial where there's strict inclusion and exclusion criteria and a strict protocol, who's participated in a clinical trial? Right? So it's like, okay, you got to come in every 12 weeks, all right, and you get 7 days on either side, right? Otherwise, it's going to be a protocol violation, and we don't want that, right? So it's very regimented. The advantage is it gives us very rigorous, pure data, but it's not as muddy or real life. In a registry, people enter the registry and say, I'm going to enter, or you can look at my record and pull my data, and the data you pull is just what happened to me. If I have a pulmonary function test, it's because my doctor ordered it, not because a protocol said that they had to order it. If I was treated with a medication, it's because we decided to use that medication, not because I was protocolized and assigned that medication. So it gives a much more real-world look at the behavior, treatment patterns, outcomes for people with various types of lung disease. So the registries exist all across healthcare. They can be disease-specific, like ours is on fibrotic lung disease. But there's registries for diabetes, there's registries for cystic fibrosis, other types of diseases. But the idea is that it's kind of real-world data collected over time to help better understand the diseases that are captured within the registry. The Pulmonary Fibrosis Foundation Registry, we have 2 databases, one that we've completed, although the data are still there, and then one that we can now be growing and actively engaging and participating in. The goals of those registries at the center, much like what Jessica said in terms of the CCN, the heart of it is to improve patients' care, quality of life, quantity of life. And with the registry, we can help do that through research. We can help do that by informing practice patterns. We can look and see how often were patients seen, and did it make a difference in terms of outcomes if you were seen 4 times a year versus twice a year. We can use data for advocacy. Let's collect data on oxygen and find out how poor oxygen is, and then have those data that we can use to advocate for improvements. And we can engage in the community, reach out. Andy Limper, Mayo physician who's here, says, we need an army of warriors for pulmonary fibrosis. And the registry is part of our artillery in that army. Registries take a long time to mature and develop, and they evolve over time. One of the kind of aircraft carrier, Veterans Day tomorrow, aircraft carrier registries, kind of a flagship, is the Cystic Fibrosis Foundation Registry. It's done incredible things to improve the care and outcomes of patients with cystic fibrosis. But what I didn't realize until I read this paper many years ago is it actually started before I was born in the 60s. And it's still going 50 years later, but it takes that much time to be able to develop the data, the power, the outreach, the prevalence of knowing about it to have those types of impact. Ours is a little bit younger. All right, so 10 years ago when the Care Center Network started, we started thinking about we should do a registry. Started fundraising to get funds to do a registry. Took years planning. What does the protocol look like? What are the centers going to be? And it was a few years after those initial discussions in 2016 where we enrolled our first subject. My study coordinator, Candace, who just left for another session, was the person who enrolled the first subject in the registry at Michigan. And we had a budget to enroll 2,000 subjects. And we did that enrollment, you guys that were in that were part of that, in just over a year. And what we realized, we were limited by budget, not by interest. We had to turn people away and say, sorry, there's no more space in the registry. So that was something we put in the memory banks to look at further. As data started coming into the registry and then maturing over time, people could reach into the registry and start to do studies. And so first we had abstracts, very short research blurbs that are presented at meetings, and then those matured into the development of manuscripts. And that's really just over a short, 5-year-ish type of time frame. So I think the energy and momentum are there in the future with that type of history, I think looks very bright. So what did this first version of the registry, the center-based registry, look like? So 2,000 people signed up and gave permission to be in the registry. The coordinators at those sites went into the medical record and pulled out lots of clinical information. What's the diagnosis? What are other things going on? Do you have heart disease or cancer or diabetes? What medications are people taking? What are some basic lab results? What are those pulmonary function tests, which for me, it's kind of like going to the dentist, right? I mean, those things hurt. Collecting that information. We also got CT scans. It's really the diagnostic cornerstone for interstitial lung disease, but also we use these sometimes to follow changes over time. So we asked if you had a CT scan around the time of enrollment to upload the CT data, the raw data that makes the images, not names and things like that. And then 2 subsequent ones. So we could have CTs that were changing over time. Patient-reported outcomes, some general quality of life measures, measures of fatigue, measures of cough, measures of shortness of breath. And not just how you're doing today, but specific quality of life or patient-reported outcome instruments. We collected hard medical events. Did you die? Did you get a lung transplant? Were you in the hospital? All things that we want to avoid. And then about 90% of people stuck out their arm and said, yeah, I'll give you some blood. And you can use that blood into a biorepository where we can have DNA, RNA, different types of processing of the blood samples to do biomarker research. So this registry closed last summer. The data are all still there. It still can be utilized, but new data no longer are going into it. So what we have is stopped for this kind of first version here. But just over that 5-year period with just over 2,000 subjects that volunteered to be involved, look at the power of the data that were there. 1,600 blood samples, that's a huge biorepository. And that's not each one of those collections gets broken down into many, many different samples that can be used in multiple different studies. Almost 3,000 CT scans to do radiographic studies. Information from over 8,000 doctor visits. Almost 15,000 pulmonary function measures. So huge amounts of data were collected in a very rigorous fashion. But as time goes on, you start to think, well, how could we do this better? How can we evolve? We didn't think of things at the beginning that we thought of them a few years later. The first was, how can we increase participation? We were limited at the sites with a budget to do 2,000, but that was not because there were only 2,000 people that were interested. There were a lot more interest. So how can we increase participation, not just at the sites though, but how can we broaden? Those first 2,000 subjects had to go to a care center site, so they were able to get there. They were seen there, and they were enrolled there. But what about everybody in the community that maybe doesn't go to one of the care center sites? How can we increase the outreach beyond just the care center sites? So a huge goal moving forward was for us to be able to increase participation. We wanted the ability to interact with people on the registry if they gave us permission and said, yeah, you can contact me. You can communicate with me. In the first version, when we started this, each center had its own IRB, an institutional review board. So an IRB is a group of individuals that review study protocols to make sure that the study is done in a safe way. The idea is ethically looking at the consent, is this study protecting the subject? Okay. Well, in the first version of the registry, every center used their own institution's IRB. So if we wanted to change something, we had to go to 40 different IRBs and ask 40 different IRBs, say, hey, here's our new protocol amendment, wait for them to approve it, and then implement it. It's just not feasible. So we didn't have the ability to interact. And if we wanted to interact with subjects, we had to go to each of those IRBs and say, we want to reach out to these subjects with this question. Will you give us permission to reach out? All right, so we wanted to change that. We wanted to be able, from a foundation level, to interact with participants that give permission to do that. We wanted to increase flexibility on the ability to modify the data or expand or change the data that we were collecting. So we did both of these things. By now, the registry, the community version, the one that's active right now, has a central IRB, one institutional review board that reviews the study for the entire country. So we have one point of contact. And so we can say, we'd like to send out this questionnaire. We're amending our protocol, and we're going to ask these questions. IRB looks and says, seems like good information. You have permission, and we can do that. Much more efficient in terms of being able to outreach and go back and forth. We want to minimize site burden. Instead of having a coordinator at each site going into the record and pulling out all those data, well, how about this engaged subject who's interested in part of this cause? Can they enter the data on their own so that the site doesn't have to be entering that data? And the goal of all this is to increase the pace which we can move things forward in the utilization. So we had started with a center-based 2,000 subjects. Those data are still there, but now we're hoping to increase the number and the scope and the outreach through this community registry. So is anybody here in the community registry? Right. So how do you get involved? You can go to the website, the Pulmonary Fibrosis Foundation website. Wonder if there's a talk that's given this week where we don't mention the website, because it's got a ton of really good information. But you can go to the registry part of the website and click on pffregistry.org, and there's this doesn't project very well, but there's a sign up button. When you click on that, it takes you to an electronic informed consent document. That gives you more detailed information about the study, the types of, like how much time does it take, how often do we contact you, what are you collecting, talks about the safety around your data. So the security, the data security for the registry is the same level of data security for your electronic medical record. It's the highest level of security that we can have, realizing that hackers are always out there trying to figure out ways around things. But it's very secure. So it's anonymous data, not personal information that researchers could use. You can give permission to say, I'd like to be contacted with more information or information about a trial that might be near me or another survey. All that, of course, is voluntary. It's not making you participate. Or you could say, no, I'm going to put my data in, but I really don't want to be contacted. I get enough emails. So you get opt in or opt out of that, of future communications. We also wanted to expand and not just collect information on patients with interstitial lung disease, but also what about those patients that had a lung transplant? How are they doing? What's their quality of life? Also caregivers. You know, the person that comes to clinic with you, helps get you to clinic, who helps you through this process. What do they look like so we can be a better resource for caregivers and understand how their lives are affected by this disease, even if they're not personally having the disease. And then family members, to try to understand some of the potential interactions around family and fibrosis. We collect demographic information. That's the royal we, right? Because now it's you as a subject entering this data. So entering information on who you are, what's your age, your sex, your diagnosis, what's your other medical history, what medications are you on. There's some patient-reported outcomes. They're a little bit different than the first version just because we've evolved some, but specific instruments that can be used for research around patients reporting their impact in terms of cough, fatigue, and symptoms. Where is this? So this started, this opened in July of 22. That's where we went live with this. As of when I looked at the data making these last slides last week, November 2nd, almost 1,800 individuals have signed up for the registry. 67% are patients, and 80 of those, nearly 1,800, are people that have had a lung transplant. 25% of those 1,800 are family members, 18% caregivers, and we're almost 100% state represented across our country. This just shows the pace of enrollment along the bottom, just gradually increasing. My hope is that when we look at November, December, after the summit, we see a sharp change in the slope for the good direction, that it's going up exponentially higher, and we get a huge uptake in people being aware and participating in the community registry. This is a busy slide, but it just gives us kind of a 20,000, 30,000 foot of some big types of data that are in the community registry. And I show it because it's a really good, easy example of how we can learn from this. If you look at that top left box, which I know is hard to read, it says patient medical information, and right below that, it says patient knows their diagnosis. 21% said no. And I thought, as a doctor, I'm like, oh my gosh, 1 of every 5 patients that I'm seeing, maybe more, are leaving my office, going to their car in the parking garage saying, I have no idea what Kevin said. Right? I mean, that's probably not surprising, right? I mean, but it gives us opportunity to say, how can we change that? That's horrible. So how can we provide information to providers, to patients, so we can better communicate on what we're all trying to treat? And that's the diagnosis. We can get information on who's on antifibrotic medications. And you can click on these different diagnoses, and it will drill down. You can say, well, how many people with this disease are on this antifibrotic? What about oxygen therapy? We collect information on oxygen. So very high level types of data, but just even at that high level, you can start to see how this could really be impactful in helping us define areas of need and then target those with more research and advocacy. So the brochures are available at pffregistry.org. You can go to the website and click join. You can join as a patient or a family member or a caregiver. The forms, again, things are evolving. So the name of the database that we used initially and still using is called REDCap. It's a university-based secure system, but it's very clunky. All right, I'll be honest. Those that have done it, it's clunky, right? It's not user-friendly. So we're in the process of finding a new vendor that can be the face, so it's a much more user-friendly interface. Still same security, but that it's just not so academic-facing and looking. But when you sign up, you complete the baseline forms, which may take an hour or two, but you can come and go. You don't have to do it all in one sitting. You can come and go. And then every 6 months, you get a reminder that says, hey, could you go update? Those are much shorter because most things haven't changed, but maybe your medicines are a little bit different, or your oxygen use or something is different. And so you can update things and move forward every 6 months. There are way more than 9 unanswered questions. We could probably get 9 different questions from every table in this room. But this is just a snapshot of some unanswered questions and things that we can try to answer by getting data from the registry. How do people use this? So is it a free-for-all? No. If investigators are interested in using the registry data, they go to the website and they click on Submit a Proposal. And it's a fairly brief proposal, but they ask, what's your hypothesis? What are you studying? What types of data do you need? How are you going to analyze it? So it's kind of a little bit of a pre-scientific review to make sure that, yeah, that's a question that's not already been looked at in the registry. The data are there so you can answer it, and the way you plan on looking at it seems reasonable. Once that goes back and forth and gets sorted out, then the data, just the data, not names or identifiers, but the data get released to that investigative team, and the data get analyzed and eventually, hopefully, published and disseminated, and the field moves a little bit further forward. And that's what's happening. I loved putting this one together. I could have put several of these slides together, but these are just from various journals. Each one of these studies or abstracts are moving the field forward through research based on data that were in the registry. If the registry didn't exist, this would be a blank slide, because without the registry, these studies would not have been able to be done. So with that, I will stop. I will thank those of you participating and pre-thank those that are going to go back to the rooms and sign up. And be happy to answer any questions. So thank you so much. Yeah. Yeah, so because of the study that came from about wind instruments used that verbiage, so we put that verbiage into that. But really, we could have broadened that and said wind instrument, reed instrument. But it's based on where the data that might be associated with ILD in some cases, where that came from.
The curious thing for me was my sister passed from IPF in '97. She also played the clarinet. Are you looking at familial?
So there are questions around familial, and again, that will hope. There's a lot of things that we want to be able to build into this registry. So, for instance, one thing that we don't have right now are the ability to collect those biosamples. So we don't have that ability. So we could make potential family connections. Some of the questions that, as you know, ask about, do you have family members that have that? So we can make some kind of high level, reported associations, but we don't have any ability with this current version to say, well, let's look at the blood or genomics of those and see how they might be linked. Great questions.
Is there a registry for scleroderma by any chance, as an offshoot, because that gets lumped under
Yeah, so so the question is there a registry for patients with scleroderma, which is an autoimmune disease that affects not just the lungs, but thickening of the skin and other organs. The Scleroderma Foundation, I think, has their own registry specifically for scleroderma, but patients with scleroderma and lung disease can be in our registry as well. So any of the connective tissue diseases, scleroderma, rheumatoid arthritis, you name them, not only can they affect the joints, which is what we often think about with autoimmune diseases, but they can affect the lungs. The lung is full of connective tissue. So people with autoimmune diseases like scleroderma can get scarring of the lungs, and they are welcome in the registry, and they're specific. Those are some of the diagnoses that we ask. Do you have scleroderma and scarring of your lung? Do you have rheumatoid arthritis? Yep. Yeah, so absolutely.
Please do use the mic. We'll pass the mic to you.
Yeah, and I'll repeat the questions too.
Just so that others can hear the question as well.
Yeah, good afternoon, and thank you for the presentation. My question is, the registry is great. It holds some significant amount of data right now. What is the methodology, or what is the approach that researchers are following in order to do something with the data, as opposed to just having all this data sitting there waiting for somebody to voluntarily say, I think I can do something with it? Are there any programs that are actively going after that in trying to understand more about the disease?
Yes, the question is, the data are there, what's being done to catalyze the use of the data? And a lot of it is investigator initiated, so outreach to tell people that it's there, so that their creative ideas can come to light and do that. We have had specific proposals where we've put out and said, well, we'll give you this much grant money if you have a question that would utilize the registry. So in the past, we've taken approaches like that where we've tried to kind of stir the pot a little bit to get people thinking about it, to give them some financial resources to utilize it. But at the heart, it's really interested investigators with creative minds thinking about questions and then being able to use the data to answer those.
And I can comment on that too. I was an early career investigator, asking questions, and I think one of the ideas was kind of, benchmarking. What are there centers that have better outcomes than others, and what are those centers doing that others aren't? And a lot of that's modeled after what the Cystic Fibrosis Foundation had done with theirs, is kind of look at centers, what aspects of these places or things that people are doing are leading to better outcomes, so that we can then extrapolate that and then harmonize that to everybody else in the care center network. So it's kind of, can we improve care delivery?
I just wanted to know, what methods are you doing to encourage patients to go to the PFF website to enroll for the study? And I also work at a care center. This is the first time I'm hearing more about it. What can I do to encourage patients so that they can enroll in the registry?
Yeah, so the question is, how are we getting the word out? And so, from a foundation level, we've done some registry awareness pushes where we've tried to push out information through social media or extras, talking a lot about it at this meeting, and then hoping people will go home and talk about it in their support groups, to their doctors. We're trying to get the word out. That slope I showed you is encouraging, but I think it's just the tip of the iceberg. I mean, it's been a year and we don't have 2,000 people yet. It's about the same pace as this other one went, but there's so much more opportunity. What I do in my practice is I have a stack of those flyers that I have printed out, and I take them into all my patients, and I give them to them and explain the registry, and ask if they, take it home and consider signing up. And then I put a note in the chart that says I did that, and then when they come back next time, I said, did you do that? I forgot. Okay, next time. Or if they did, I'm like, great, thank you so much. It really is, you guys can be so instrumental in getting the word out. We really want to reach those areas that aren't reached, and it's hard. It's hard to get out there. So a lot of it's going to be word of mouth, and I tell 2 people, and they tell 2 people, and they tell 2 people, and the next thing you know, there's 20 people that know about it that didn't know about it before.
Yeah, that's how the Care Center Network and the registry work together as well. We ask the providers at the Care Center Network to distribute that information out, and there is, at the exhibit hall, more information, and those actual flyers and things are available today too.
I'd like to ask a question about the family part of the registry. I don't have, to my knowledge, familial IPF, but I have encouraged my children to register, and I just wanted to know how important it is to have that kind of input in the registry.
I think we'll find out. To be honest with you, we didn't look at it before. No one's really. There are some centers, Vanderbilt, National, that have specific interests and have followed, cohorts of family with familial fibrosis to learn some about that. But, if you ask generally across the country, how common is it for people to have a 1st or 2nd degree relative with fibrotic lung disease? We don't know the answer to that. If we start getting those data in and see that, then that opens up a whole new opportunity to say, whoa, it's not that common. Okay, don't worry as much. Or it really is common, and maybe those are high yield populations to screen. We don't know that now. So I think the data will be important. How important it is, we'll have to see what comes out of it.
I have a question. It's more of a mechanical question. Within the last 2 years, I've tried to register when I had IPF, and I would go back and try to log on, and I'd get locked out. And in the meantime, I've had a transplant. So would I still be eligible to register if I could figure it out?
So you highlight why we're looking for a new face page, because the mechanics of the system we have, although very rigorous, is clunky. And yes, you could go in and register as a transplant recipient and participate in the registry.
Hello, thank you so much for this panel discussion. It's been very enlightening, and I did want to tell you that for some of the outreach, the reason we are here, my husband and I are here this weekend, is because my husband was at CVS. He has pulmonary fibrosis, and he was at CVS picking up a prescription, and it came over the loudspeaker that for more information on pulmonary fibrosis, contact the foundation. And that's how we found out about this. We were in Massachusetts at the time. And so that's a great resource. And I would just encourage you guys to get into all the pharmacies, because that's where we are, right? We're all going into the pharmacies to get our prescriptions at this stage of our lives. But anyway, that's all I wanted to say. Thank you.
No,
yeah.
thank you. That's good.
Yeah.
Good.
And CVS has been a great partner in that. And you probably heard there, maybe during September, the Pulmonary Fibrosis Awareness Month, that's where we really put a push into all of these different activities. We collaborate with other foundations as well. And that's where, as well, you'll see kind of the buildings blew up for PF and things. So that's the month of September.
The color blue.
Mm-hmm.
Not
Yeah. Oh, yeah, blew up the building like, with lights.
All right.
Any further questions? One more in the back. Yeah.
So I echo the sentiments of others. This has been very, very helpful, very informative. When the conversion takes place from REDCap to whomever the new provider will be, is it correct to assume that the information for those of us that have entered data, it'll transfer over?
Yes, the data behind the scenes will all still be the same. It's just finding a better interface so that it's more user-friendly to get the data into the database.
Thank you.
Yeah, great question.
So my primary role at the foundation is how I like to look at it is the clinical outreach. And what that means to me is working with all of the healthcare providers who are caring for patients with interstitial lung disease and their families. I love pulling on my nursing experience, my research experience to better inform our care center network, along with helping out understanding what patients' needs are and communicating that to providers, and then also providers coming back and informing me of what they're learning at their centers. So Dr. Benty and I have worked on a number of initiatives, one in particular around best practices. So what are some of the standard of care activities every provider should be doing is what we've been working on together. And so I'm really primarily working with our medical centers. And I think you all know the mission of the PFF, really around, a cure, but that until that comes available, we want to mobilize people and resources to provide high quality care and lead research for a cure for people with pulmonary fibrosis to live longer, healthier lives. And when we think about the care center network in particular, we want to propel the field of pulmonary fibrosis through optimizing diagnosis, so making sure folks are able to get diagnosed quicker, more accurately. Patient-centered care, so bringing what the patient needs to them and bringing their perspective into it. Making sure patients and their families have education that's relevant to them, and then also facilitate research. Our vision is that every patient receives a prompt, accurate diagnosis and receives the highest quality patient-centered care. So that's a lot of mouthful, right? So I hope that I can share with you all now a little bit more. What does that really mean in day-to-day and what that might mean to patients and their families? I talked a little bit about, what our, mission was, and it's really grounded in these 4 goals of the network. again, improving diagnostic process. So making sure that folks, when they have symptoms and they need to be evaluated, that they're getting evaluated quickly and that they're getting an accurate diagnosis so that their treatment plan can be appropriate for them. That leads right into enhancing quality of care. So we want to make sure that patients get what they need, really drawn upon what their diagnosis was and what they need. The third goal is accelerating research. So we know to get to a cure, to be able to understand how better to care for patients living with the interstitial lung disease, we need research. And research might be facilitating things that happen in a petri dish, all the way to helping understand, okay, we have a therapy for pulmonary fibrosis, an antifibrotic. How is that happening in the real world? You know, are patients being diagnosed? So we really cover that whole spectrum of research. So all the way from petri dish to helping understand what kind of new therapeutics could be developed, all the way to once we have a new intervention, are we making sure that in the real world with real patients, it's working the way it's intended to? Lastly, the PFF is really, we're a patient advocacy organization. And so what's really important is when someone like Dr. Benti is seeing a patient and he has a problem, that patient has a problem, and then he sees a patient the following week and they have the same problem, like access to oxygen, it's really important for our healthcare providers to inform us on what they're witnessing and the struggles they're potentially having, or maybe what's working really well, so that we can advocate for that. We're lucky enough to have a team at the Pulmonary Fibrosis Foundation. I'm Jessica, as we know, and then Ingrid is our manager and Aubrey's our coordinator. And we have all of are available to everyone. And typically when patients are calling, they go through the help center at the Pulmonary Fibrosis Foundation, but sometimes we get the questions and we try to have those answered as appropriate as necessary with the Care Center Network, but typically providers are who's reaching out to us. One of the huge accomplishments that we're celebrating at this summit is that we are celebrating the 10-year anniversary of the Care Center Network. So it was a short 10 years ago that the first 9 centers started the Care Center Network. At that time, it was revolutionary to think that we could get medical centers together, all working together, to improve care to pulmonary fibrosis. It was a time where, we were just, antifibrotics yet weren't all approved, and there was a lot of activity around that, developing the new therapeutics, but we wanted to get folks all together, medical centers that we knew were providing expert care, and understand what could we do to build that research network. Now, many of you may have already just sat over to in some of the other sessions, or you'll hear more, but I wanted to just talk about kind of our structure and leadership because I'm a nurse. I have staff that are not medical providers, but we work really collaboratively with folks within the PFF who are providers as well. Dr. Frank Rahagi is our president, CEO, and chief medical officer. He provides a lot of oversight and guidance. He joined us in September. And then I also have 4 medical team advisors who are here at the summit who provide expert consultation to us on how to inform us on how some of our strategic plans should be going, our goals. And you'll be hearing from Dr. Kevin Flaherty momentarily on the registry. I work very closely with Sonia Danoff as she advises on the Care Center Network, Dr. Joyce Lee, who advises on research and health outcomes, so that would be what I was talking about at best practices, what should be standard of care for every patient living with interstitial lung disease. And then Dr. Amy Case, who really works on education and awareness. So a lot of the education materials you all see from the PFF, Amy has had a significant impact in developing those along with the PFF staff and the programs team. So just wanting to deep dive a little bit more into what is the Care Center Network. It sounds great with these medical centers working together. What does that really mean for patients? And what comprises the centers that are comprised the care center network? Well, there's 81 care centers and 7 clinical associates. Care centers have been around since that 2013, and what's really exciting is this year is our first year that we welcomed clinical associates. And I'll explain a little bit more on the differences. The main goal is that they have expertise in treating adult patients with an interstitial lung disease. Again, they have to have that multidisciplinary approach, which multidisciplinary means that you have all of the team players together to care for the patient. So potentially definitely a pulmonologist, potentially a radiologist, pathologist, a rheumatologist, the nursing staff, anyone that can help contribute to caring for the patient. They have to be present at a care center, along with other ancillary folks, respiratory therapists, social workers, making sure that all of those wraparound services are available to patients. Again, you'll hear these over and over again, where it's delivering good care, engaging with patients in research, education materials are available for patients, and then also our care centers and clinical associates engage in the local community through PFF programs. That might be a PFF walk, or some of our other activities such as patient events. So again, the Care Center Network engages their local providers to get all of those education and research activities, and members use their local expertise and PFF programs to engage other providers in the community who need to be informed about what an interstitial lung disease is. So I said I would talk a little more about clinical associate designation and what that means. So about 3 years ago when I joined the PFF, we knew that the Care Center Network were in primarily larger academic medical centers. And what we wanted to do was allow further expansion of the Care Center Network into centers that might not have as large of a care team, have access to all of the resources that we know are important for care delivery. But in areas that are very rural, having all those resources locally to a patient's home can be challenging. So we really spent a lot of time over the last 2 to 3 years understanding what is required for some of these smaller clinics to be designated as a care center network. And that is what the clinical associate is. They're members who are more in a community-based institutions that partner with care centers in order to share resources such as access to research studies, lung transplant, to make sure patients are receiving what they need. So this is just another graphic to show that in 2000 the PFF was established. We had 9 centers in 2013, and we've slowly grown to those 81 care centers, and then again this year we added on 7 clinical associates. This is one of our maps that just shows our coverage and growth. Our goal, this was care centers in particular, before we added on those 7 centers of the clinical associates. We were able to add more representation beyond the care centers in those clinical associates. So this is a really busy slide on purpose, just to give you a snapshot of all of the different care centers that are present in the network now. Some of you may see your care center there, or a local, someone that you know of. And these are the new clinical associates. So we were able to expand care in representation into Delaware, New Mexico, Maine, South Dakota, along with some of the other areas in Pennsylvania and Tennessee that didn't have representation of a care center locally. Now, I went ahead and talked to you at a high level of all of what is the Care Center Network, what are care centers, what are clinical associates, but how could a patient find care locally to them? And we have the PFF Find Medical Care tool. This also can be utilized to find a local support group or a clinical trial. But we have this tool on our website that you put your zip code in and actually be able to find your local care center. What represents here is the local care center to me. I live just outside of Chicago, and Loyola University Medical Center is the closest to me. I could also filter this tool more to add support groups and clinical research, as I mentioned, so that you could see what's the nearest center to you. Alternatively, if that is something you're not interested in going on the web, you can always call our help center to get more resources to you via the phone or email to understand what resources are near you at home. So one thing I wanted to talk about is some of the other activities the care center does. It's, they're really, the providers at these centers are there to provide primarily care to patients living with interstitial lung disease. But remember, we said that research is really important to continue to advance the science. Also, this is another opportunity for us to get word out of what potentially should or shouldn't maybe happen to interstitial lung disease patients. And we have the PFF position statements. Now, the great thing with the position statements are they're typically statements that are developed around a particular topic that doesn't have a lot of hard science, and we know exactly what to do when and guidelines around it. But it allows us to bring experts together, including patient representation, caregiver representation, and to develop out consensus statements. So this helps patients. There's patient-facing statements along with provider-facing statements. It helps us bring some of those complex topics down to an easy couple-page statement for folks to understand. So the role of surgical lung biopsy, genetic counseling and testing, this was just updated in August and provides a wealth of information around familial PF, along with patients who are just interested in genetic testing, telomere length, what should I do? We have a stem cell position statement that actually advises against stem cell treatment unless it's in a FDA-regulated clinical trial. We have protocols for providers around how do you do CT to get that accurate diagnosis, a chest X-ray, chest CT, CAT scan. Palliative care. This is really important about symptom management, and if a patient is struggling with symptoms such as cough and some other things as potentially things progress, palliative care is a really awesome resource that's available. And this just was released actually October 2021. What was supposed to be there was the pH related to ILD position statement that was just released. Pulmonary hypertension related to interstitial lung disease can be really important for patients and providers to understand that pulmonary hypertension can actually be something that should be evaluated and assessed by your physicians if you have a worsening of symptoms. And so we have those. That is written right correctly. I'm so sorry. And so that position statement was just released, and it goes through for patients and providers kind of the things that you should know about pulmonary hypertension related interstitial lung disease. Shortly after Summit, we'll also release position statements about rural health. We know a lot of patients live in rural America, and some of the risk factors for developing pulmonary hypertension could actually have a higher percentage of folks living in rural areas. And so we wanted to develop out statements that helps connect resources such as clinical trials, support groups, palliative care, specific to those living in rural areas. So those are going to be released real soon. These all can be found on our website. Additionally, we know that physicians aren't the only ones that are caring for the patients, and we talked about how important it is to have that multidisciplinary approach to care. And so we have the Nurse and Allied Health Network, we call it the NON, and it's really to encourage the collaboration and professional development around this scope of practice, which means nurses, social workers, nurse practitioners, physician assistants, pharmacists who are locally at a center can all come together for professional development and come together. There are some centers that might only have one nurse in a clinic, and when they are struggling with a particular clinical problem, they have someone to turn to, the whole network, to ask questions. How did you address this, oxygen question? Or how did you get a prior authorization approved for this medication, for this condition? So our Nurse and Allied Health Network is a resource for all of those providers as well. We have some wonderful co-chairs, Jamie and Janelle, who are both nurse practitioners who help support that group. So I just wanted to say thank you. What the Care Center Network is really, again, the clinical outreach from the foundation that's bringing providers together in a way to partner, collaborate, to improve the lives of patients living with pulmonary fibrosis. Thanks.